present about surgery in chronic pancreatitis. So I will restrict it to the only chronic pancreatitis and what are the surgical options available, when and where and for which purpose we require surgery in this chronic pancreatitis. So as we all know that chronic pancreatitis is a irreversible destruction in the pancreatic parenchyma and the ductal system. This damage has already occurred and it is due to a long-standing inflammation which leads to fibrosis and scarring. Incidence are 1.6 to 23 per lakh population overall worldwide, and their prevalence is still increasing. So as this is an irreversible destruction, only treatment is for a palliative. So only a symptomatic patient needs treatment, because for chronic pancreatitis itself we don't have any treatment right now because everything is already damaged. So I will go by symptom wise why a treatment is required.
After acute pancreatitis, time bound karo ki after 3 months we label it as chronic pancreatitis?
No sir, it is not a time bound.
Only scanning કેવું દેખાય પછી
yes, it's only imaging we can say that it is chronic pancreatitis. Even
calcification and fibrosis is much.
Yes. So that is only on imaging we can tell that it is a chronic pancreatitis. Otherwise we can't label it.
Is that two heat phenomena? The commonest cause which you are mentioning, all do not get pancreatitis.
Yes.
Right? Many people drink alcohol.
Yeah.
How many get the pancreatitis? Very few.
Yes.
So it is a two heat phenomena. Genetic background, nature,
Yeah.
and nurture. Right? We overestimate alcohol and underestimate tobacco.
Yeah.
Tobacco is
Smoking also.
so tobacco.
Yeah.
Equally culprit, but how many smokers get the pancreatitis? Very few.
Yeah.
So once again I say it is a
But sir, when a study comparing compared to alcohol, smoking has a more chances of pancreatitis.
I am coming to that only.
Yeah.
So it is a two hit phenomenon. Alcohol has been amplified,
Yeah.
right? While smoking has been negative. Both are equal culprit
Yes.
for a chronic pancreatitis.
So most common symptom which needs treatment is a pain. Almost 70 to 90% of patients with chronic pancreatitis will have a pain, and which will ultimately lead to a severe pain which requires some treatment for them. Other treatments for complications like bioduct stricture or pseudocyst formation, portal hypertension, then duodenal stricture and pancreatic head mass. When most of the patient treatment is required for this process. Rarely there may be a duct disruption and leakage of pancreatic juice into abdomen which lead to pancreatic ascites, then pseudoaneurysm and exocrine and endocrine insufficiency in chronic pancreatitis. So we will focus only on where surgical treatment is required, and I will go on symptom wise where we can do it with the surgery. Firstly, we have for pain, which is the commonest symptoms. Why this pain occurs, the mechanism is poorly understood, but the most accepted theory is a ductal obstruction due to a stone or stricture. So with the obstruction there will be a dilatation of the main pancreatic duct, and there is increased pressure in the pancreatic duct, so which leads to a pain. Other theories are like peripancreatic inflammation, entrapment of sensory nerve. Then due to pseudocyst, there are extrinsic pressure on the other organs which lead to a pain and nociceptive transmission. So this theory of ductal obstruction is well understood, and also it has been known that releasing this increased pressure of main pancreatic duct will lead to decrease in the pain. So majority of the procedure are also directed towards the decreasing this ductal pressure. So for pain treatment, initially always try for a conservative treatment like stopping alcohol, smoking. Start with analgesics like NSAID and narcotic, and if still pain is not controlled, then we can go for second stage of with pregabalin or antioxidants, mainly a methionine containing antioxidants. These are very helpful. But still, even after this, 30 to 60% of the patient fail to respond to this treatment in case of chronic pancreatitis. So we have to go for the next option.
Over a period, 30 to 60% over a period of what?
Sir, there can be 3 months to 6 months. This conservative treatment we can try for 3 to 6 months. So next option will be either an endoscopic treatment or a surgical treatment. And for stone, there is also option of ESWL. So when we should go for this treatment, endoscopy, ESWL or surgery? Choosing this option depends on the duct morphology, particularly the duct diameter. Because the dilated duct is very easy to go for a surgery, and also for an endoscopist, dilated duct is good for them also to do a stenting or any procedure like that. Presence of stone, also the location of the stone in the head or near the body region or in the tail region, because the head region stones are more amenable to endoscopy rather than a tail region stone. Then associated with inflammatory mass, because almost 30 to 50% of patients over a period of time will have an inflammatory mass in the head region mostly for chronic pancreatitis. Also the localized or diffuse complication, and then if there are associated other complications with the pancreatitis. So all these factors will decide whether which option we should go.
These are options of plumber. Cardiologists are doing plumbing in the coronary artery.
Yes.
You are going to do plumbing in a pancreatic.
Yes.
You go for EUS for detecting previous files.
Pretty much.
That can be detected with CT scan also, so no need for US. So endoscopically particularly we will go to a ERCP. ERCP is useful when the stone and stricture is confined to the head and there are only limited stone are there. So they will do a sphincterotomy and remove the stone with Dormier basket. But the stone size should be less than 5 mm. If the stone is more than 5 mm, it is difficult to do a ERCP and remove all the stones. Then the next option comes is the ESWL. ESWL is preferred for a stone which is larger than 5 cm and when the stones are more than 3 stones but less than 5 mm. ESWL is useful for a stone located anywhere in the pancreas, but still it is better for the stone in the head region compared to the tail region. After ESWL, stone may get cleared automatically or we may require ERCP. So mostly after 36 hours, if the all the stones are not cleared, then again do a ERCP and remove all the fragmented stones. Now if these two procedures are not available or they are not indicated, then the last option comes is the surgery. So obviously the stone in the entire pancreas or larger stone which cannot be break by ESWL or not amenable to ERCP, and when this procedure fails, the option available is the surgery. So in surgery, what we do is open all the pancreatic duct. This is a pancreatic duct from head region to the tail region. Initially they used to do a lateral pancreaticojejunostomy in which in all this region the jejunum was anastomosed with this part. With the advancement, people have started doing the head coring because the theory is that the majority of the pancreatic volume is in the head, and also the most of the symptoms are mostly related due to the head region. So now people have started doing the head coring in which the entire part of the pancreas is cored out or resected out, and jejunum is anastomosed from this level to this level. So all of this pancreatic duct is now open and it is clearly draining into the jejunum. So it leads to decrease in pancreatic duct pressure and pain will be reduced. So there are there are after some time there comes a question that whether we should do a endoscopy or surgical drainage. So there was a comparative study between long-term outcome of endoscopy and surgical drainage. So in this study it was found that hospital stay and cost were comparable, but overall endoscopic procedure required is more compared to a surgical procedure. Also the 47% of the patient, almost half of the patient on endoscopic group eventually had to undergo a surgery. Otherwise there was no difference in these two. So it was found that also that surgery was still superior in terms of pain relief because all of the pancreatic duct was drained into a jejunum. There is another study also. This was ESCAPE randomized trial published in 2020. This study is from Netherlands. From 22 departments of different hospitals of Netherlands, and they also found a similar result. But the patients were less. Only 88 patients were there, and they also found that with the endoscopic first approach, complete or partial pain relief at the end of follow-up was more in early surgery group than the endoscopic group were. Also, the total number of intervention required were lower in the surgical group. Rest of the things like complication, mortality, hospital admission, pancreatic function, and quality of life were similar in the both of the group. So ultimately, the treatment should be patient tailored. But they have found that surgery, early surgery, is a good option for lower pain score, and also it was found that early surgery will reduce the progression of the chronic pancreatitis, and also the deficiency of exocrine and endocrine insufficiency will be less when the early surgery is performed. Because in endoscopy we only do a stenting, so ultimately it might be that the pancreatitis is still progressing and the damage.
So in the procedure we are anastomotic jejunum with the main pancreatic duct.
Yes.
Right? We are not intervening pancreatic tissue in between.
No.
Right? Otherwise chronic pancreatic inflammatory process will affect the outcome. Okay.
Yes. Yes.
Okay.
Okay.
Like
So
both the centers were from Netherlands,
yeah.
right?
Yes.
So most of this procedure is Netherlands.
Yeah. So next complication is a biliary stricture, which occurs due to chronic pancreatitis. Still, the asymptomatic patient only needs a close monitoring. Intervention is required when there is a symptomatic cholangitis or there are biliary stone. When the biopsy evidence of biliary cirrhosis, it is also advised that after every 6 months to 12 months, in a patient of chronic pancreatitis, we should do a liver biopsy on a regular interval to detect the biliary cirrhosis. And if there is a biliary cirrhosis, we need some intervention for this patient. When then there is a progression of obstruction, persistent jaundice for more than a month, or alkaline phosphate more than 3 times for a month. So again in this also endoscopic and a surgical treatment, but the endoscopic treatment is useful for short term only because these are the irreversible changes. So if a stent is kept for long time, then there is chances of stone blockage, and also it will lead to a recurrent cholangitis. So stenting should be done only in a patient who are high risk for the surgery, or when a patient is not fit to stabilize the patient prior to surgery. Only in these patients stenting should be done. Otherwise, before biliary stricture, surgery is a good option. Surgical treatment has an excellent long-term result and with acceptable morbidity and mortality. The procedure performed are the choledochoduodenostomy and choledochojejunostomy, in which the bile duct is anastomosed with either duodenum or jejunum, depending upon the location and anatomy. Other causes are like pseudocyst can also cause a compression over the bile duct, and which might lead to or we need that it is due to a bile stricture we think, but it is due to extrinsic compression from pseudocyst. That in that case only a drainage of pseudocyst is required, and when the pancreatic head is compressing, then the pancreatic head resection. So this is a surgical procedure in which the bile duct here is anastomosed with the jejunum. Jejunum loop is taken from it was this A and B side were there, and it was resected from this, and this jejunal loop is anastomosed with the bile duct. So it is choledochojejunostomy, and this remaining loop is again anastomosed with the jejunum, which is called jejunojejunostomy. So this will relieve. Obviously, this procedure is above the level of the stricture. So stricture is below this level, which part is cut off, resected, and then above this level, anastomosis is done between the bile duct and the jejunum. Similarly, if the anatomy is preferable, we can do this with the duodenum also, which is called choledochoduodenostomy. Now the yeah. So mostly everyone prefers to do a jejunostomy only, because jejunum is freely lying, and we can take whatever part we want.
To enter into that area is a nightmare.
Yes.
એવું કેલોટ્સ ટ્રાયેંગલ કહેવાતું ને શું કહેવાતું?
Kellogg's triangle તો easy to dissect છે. Kellogg's triangle માં તો almost every cholecystectomy માં dissect કરવાનું જ હોય છે. એમાં cystic duct અને cystic artery હોય છે.
This is called periampulary region. આ જે હતું એ કયો region કહેવાય?
Region નામ તો નહીં, liver pad region નું exact નામ તો નહીં ખબર, but Kellogg's જે છે એનાથી નીચેની સાઈડ આવે, એટલે Kellogg's તો dissect કરવું easy છે, પણ Kellogg's થી નીચે CBD આવે, એનાથી ઉપર તો cystic duct અને cystic artery હોવાના.
એટલે little above ampulla. ampulla ને થોડુંક ઉપર. મારે એક ક્વેશ્ચન હતો પ્રકાશ કે have you ever operated face?
Yes sir.
કેટલા?
Almost એટલે independently કરે, પણ દિલ્હીમાં તો ત્યાં 8 થી 10 આશિત કરે.
All were diabetic or they were not diabetic?
No sir, all were not diabetic.
All were not. At least 1 or 2 were?
3-4 were diabetic.
Okay. So what happened in the diabetic status of that patient after successful face procedure?
Sir, I don't know. Long નથી. તો આપણે ત્યાંથી પછી તો અને બીજું ત્યાં પ્રોબ્લેમ એ હતો કે ઓપીડી પેશન્ટ અમારી પાસે આવતા નહીં, અમે ખાલી ઇન્ડોર પેશન્ટ જ જોતા, તો ઓપીડી પેશન્ટ તો કન્સલ્ટન્ટ પાસે જતા રહે. પછી હવે
Are you aware of any which type of diabetes this is known as?
type 3 diabetes.
Type 3C.
Yes, type 3.
Particularly type 3C. And if you do successful PRACE procedure, which started draining out the pancreas, what would you expect in the diabetic status of that patient? Insulin, almost all patients are virtually on insulin if they are diabetic. So the insulin requirement will increase or decrease?
Sir, but it will not affect that. The diabetes is still the same, because pancreatic damage is already there. There is already endocrine insufficiency.
Have you gone through the literature of the same?
No.
The literature, some of the papers are available. They are clearly stating that insulin requirement in diabetic as well as non-diabetic, both the patient increases after PRACE procedure. Number 1. Number 2, मैं जीवन में एक केस हुआ है जब मारो पोता ना तो नहीं फ्रेस कराई थी. Surprisingly, in that patient insulin requirement went down and drastically. That's just to share.
Glucagon effect है.
Yes.
Right? Which was driving the diabetes high. Now not only insulin has gone down, glucagon also has gone down.
Yes.
But
Sir,
there also more chances of hypoglycemia also.
of course, he has started having hypos. Our expectation માં નહોતું કે એનો કંઈક total daily dose around 60-70 units ચાલતો હતો, એમાંથી close to 15 unit પર આવી ગયા. And she went very well.
Because everything is good, even insulin and glucagon both are very good. The next complication which we need to tackle is the pseudocyst. Spontaneous resolution is very less. Only 9 to 31% of patient will have a spontaneous resolution. The reason behind this is a ductal communication. Almost in 80% of the pseudocysts, there will be a ductal communication with the main pancreatic duct. So, ultimately, the cyst is being filled by the pancreatic juice from the main pancreatic duct. So, till it is getting filled by main only the cysts which are not connected with the main pancreatic duct, there are chances that they might resolve by themselves. Rest of the cyst will remain or the increase in size due to a constant pressure from the pancreatic duct. And there are some complications in the pseudocyst, like it will cause a compression over the bile duct or a stomach, which will cause gastric outlet obstruction. Then it can rupture and cause pancreatic ascites. It can bleed or infection. Only an asymptomatic cyst which are less than 4 cm and within the pancreas, we can observe them. Otherwise, rest of the pseudocyst needs some kind of intervention. Again, for this also, endoscopic and surgical.
Wait after the acute pancreatitis, wait for more than 3 months.
More than 6 weeks, sir.
More than
Yes, after 6 weeks we can go for treatment.
This is with reference to acute pancreatitis related pseudocyst or chronic?
Chronic. This is for
Sir is asking for acute.
Sir, for acute pancreatitis, 6-week period is there. For chronic pancreatitis, if we found a cyst and it is fit for surgery, then we can immediately go for surgery. In acute pancreatitis, sir, what happens is there is a fluid collection around the pancreas, which is limiting or the wall, or it might become necrotic also. So initial period, even if we treat the patient, he will have a recurrence because the fluid is still not limited or it is not walled off. So a 6-week time is required to wall off this fluid and become a clear anatomy or limit the size. That's why. So initial period only we keep a drain in this area and drain all the fluid, but don't treat any necrosis or pseudocyst.
So what is the WOPN?
Walled up necrosis.
Walled up pancreatic necrosis. First differential diagnosis of pseudocyst.
Yes.
And you will never touch walled up pancreatic. It's a HEVO. But yeah, pseudocyst you need to do.
Yes.
And walled off is there are only very few indications to touch walled off pancreatic, 1 or 2. Especially infection which is not responding to your ongoing antibiotic and resistant sepsis. આ બે સિવાય કશું નથી જેમાં તમારે એને ટચ કરવાનું.
Yes. Okay, so again for the pseudocyst, the treatment option are endoscopic or a surgical drainage. Endoscopically, it can be done with transgastric, duodenal or transpapillary, in which they will put a stent between stomach and a cyst, and they will drain all the cystic fluid into a stomach. Surgically also the same procedure is being carried out, like cystogastrostomy, cystoduodenal or cystojejunostomy, in which cyst is connected with the stomach, duodenum or jejunum depending on the location of this. So this is a surgical procedure. Usually most of the cysts are behind the stomach only. So we open the stomach from anterior side and then go posteriorly, and then open the posterior wall of the stomach. We will find the pseudocyst and we will connect these two. So ultimately this cyst will drain into the stomach. If it is located here or here, then we can connect it with the duodenum or jejunum, and the cyst will start draining into the intestine. So for this study, both endoscopy and surgically have both procedure have shown high success rate, and there is no comparative study available at present with good number of data. So we can prefer any of these. Both have good result. In this multidisciplinary approach, this should be tailored to the patient and the pathology, which procedure is best for that patient. Surgery should be done when the patient has other simultaneous problem which cannot be taken with endoscopy. In that case, we can prefer a surgery. Otherwise, both options are good for pseudocyst. Okay. Now the next pancreatic head mass. The importance to this is morely because of the cancer probability. Because almost 30 to 50% of the patient with chronic pancreatitis will have a head mass, and 5 to 10% of this mass pretend as a pancreatic cancer. They are or not, we cannot definitely make sure. Even after still so many investigations, still some patients have a doubt about this. But the risk of pancreatitis cancer is 8 to 15 times higher in patient of chronic pancreatitis, and 70% of these cancer are in the head of the pancreas. Even the autoimmune pancreatitis can also form a head mass, which requires treatment with only steroids. Whereas the cancer will require a resection procedure. So, to predict this, there are some clinical indicators like when age is more than 50, we should suspect cancer. Then sudden change in character of the pain. Like pain was initially relieved after some medication, but now it's not relieving, or there is sudden severity is increased. When there is unexplained weight loss despite POD. In chronic pancreatitis, there will be a weight loss, but with pancreatic enzyme replacement, he may maintain some weight. But even if we have given enough dose of pancreatic enzyme and still he is losing the weight, we should suspect a cancer. New onset or worsening of diabetes, then jaundice, particularly bilirubin more than 5, gastric outlet obstruction due to a head mass. Yeah, these are the characters in which we should suspect about cancer. Other than this, if there is an involvement of salivary gland, history of IBD is there, then we can say that it might be a autoimmune pancreatitis. If these which are there, then we should investigate in the on the side of autoimmune pancreatitis.
IgG4.
Yes, IgG4 and cost-effective globulin level is also. If the globulin level is less than 2, then there are less chances of autoimmune pancreatitis. So, for the cancer to rule out, we need an investigation like CT and LFT and USG. Then CECT with pancreatic protocol, in which the arterial, venous and delayed venous phase are taken, and where with MRI and MRCP depending on the location. Then the PET-CT to rule out any distance metastasis also. And the confirmation will be taken with EUS biopsy. Even the biopsy has a lower sensitivity. Specificity is good, but sensitivity is low because in the area of fibrosis, to decide from where to take a biopsy is also challenging for endoscopist. So even biopsy can be a negative in some case, still there may be a cancer. So if the histological proven cancer is there, then the only procedure is a pancreatic duodenectomy. But if there is only mass forming pancreatitis is there, then fresh procedure is there. Nowadays with fresh procedure we always do a intra-op loop-up biopsy and frozen section. And if also there is no proven cancer, then also in that case also indeterminate result also we do a frozen section, and if it comes out to be a positive for cancer, we do a pancreatic duodenectomy, otherwise we will do a fresh procedure. So in Whipple's, this part of the pancreas will be resected, pancreatic head will be resected. Along with that, bile duct, gallbladder will be resected, and duodenum and jejunum will be resected. So this pancreas will be anastomosed with the jejunum here. Then this is hepatic duct will be anastomosed with the jejunum, and this stomach from where we have resected. So this stomach will be again anastomosed with the jejunum. So there will be 3 anastomosis: pancreaticojejunostomy, hepaticojejunostomy, and this gastrojejunostomy. And again some of the surgeons do different here jejunum to jejunostomy, so that this fluid will directly pass from here to the jejunum and not go reflux to the stomach, so that the reflux esophagitis and gastritis will be less. Some surgeon prefers to do this. This is called as a Whipple's procedure. Okay. Now the next complication is duodenal obstruction. Most of the time this is due to a paraduodenal edema. This edema will resolve within 2 weeks, so we should try for this as a conservative management, or we can do a nasojejunal tube insertion and feed for 2 weeks from nasojejunal tube, and edema will resolve by itself. Or it can be due to a fibrosis, or if there is a pseudocyst, then we need a treatment for pseudocyst, and if there is a pancreatic head mass, then we need a treatment for head. So Duodenal obstruction, most of the time we need a treatment for the cause which is causing, not directly this obstruction treatment. Another complication which can be tackled in surgery is a mesenteric vein thrombosis. This will lead to a portal hypertension. This entity itself is difficult for other surgeries also, because there will be most of the time there will be a lot of bleed and with a lot of collaterals around the pancreas. So it will make other surgery like the phrase or Whipple's very difficult to do in this case when there is a mesenteric vein thrombosis and portal hypertension. So we need to tackle this problem first before going for a surgery. If there is upper GI bleed, then we can do endotherapy or a devascularization, and in case of left-sided portal hypertension, we need to do a splenectomy. So these were the some symptoms and complications which were required, which requires some surgical or endoscopic intervention. So to conclude the chronic pancreatitis. Yes, sir.
When the pancreatic transplantation, suppose
Yes.
in a patient of
Sir,
chronic
pancreatic
pancreatitis with the insulin requirement that is very high for that patient.
So pancreatic transplantation, exactly I don't know, but the results are not that much good. Also, the islet cell transplantation has only very limited 30% of the success rate and very high costly. Also, very few centers are there because they need a specialized lab to isolate the islet cell from the pancreas, which is also a difficult procedure. Some islet cells get damaged during this procedure, so success rate is very low, and that's why this procedure has not become so famous over the worldwide. Even very few centers are doing this pancreatic cell transplantation.
Two comments. You have done 60% job. 40% patients are still having pain. Doing all these things.
Yes,
So my first comment was, this is a plumber's job.
yes,
Now the next job is of electrician. Celiac praxis itself is responsible for pain.
yes. Sir, this pain management team is doing serious praxis work, but the effect lasts for only 4 to 6
I am coming to it as such.
Yes,
Right? I am discussing that 40% patients.
yeah,
You become the electrician for 10% patients.
yeah,
Remaining 30%, then for another 10% you do the butchering. You remove the all part, thinking that that vein is the fertile and creating the pain as such. People have gone through all these things. And then pain originates from thalamus, not from there. So cognitive behavioral therapy start coming. Now the role of psychiatrist and physician comes.
yes,
Right? Pancreatic pain is a nightmare for patients as well as doctors.
yeah,
It is the worst pain as such, and he begs for a death.
Even there are reports of suicide due to a pancreatic pain.
Right? So somebody has to do the research from those remaining 20% patients. This is an easy thought process as such.
Yes,
60% you need it as such. Fever is like you give the malaria treatment, all right, 60%. But forgetting urinary tract infection or abscess or something.
right.
Think obliquely of these patients.